Good afternoon, and welcome to Chapter 13, the Revenue Cycle. This happens to be one of my favorite topics to review and go over with my students. Please remember that the revenue cycle has about 10 different positions within it. So let's go ahead and get started to see how that comes about. So I like to divide the revenue cycle in the front end and back office processes. Front end means that the patient has not been seen yet because we go ahead and go through registration, pre-registration, and scheduling. We all know when we have to see the physician, we make an appointment via phone, or if it's on an emergent basis, we go to the emergency room. We also collect patient data, demographic information, insurance information, and we also establish patient financial responsibility with verifying benefits and if they need pre-certification for an admission or a surgery. The back end would consider when the patient is discharged, and those processes include coding, billing, claims adjudication, payment generation statements, and collections. Okay, so coding, if you are coding /biller for a physician office, you would retrieve the counterform super bills, and you would review that based off of the documentation in the charts to determine if the E&M code is assigned properly. The important players within the revenue cycle would be patient access service, utilization management, third-party payers, of course your charge description master, your charge master, clinical departments and physicians, and healthcare information management and patient accounts. Basically, patient access units, they schedule patients for services and also do an insurance verification. Utilization management is between both the nurses, one at the insurance company and one at the facility, and they communicate back and forth the patient status to see if they are receiving or not receiving the proper care that they should be for their illness. And of course, patients' accounts, if there are any patients that owes any monies, of course, we can set up payment plans so they can begin to start paying back for their medical expenses if whatever their insurance company does not cover. All right. Accounts receivable. This is a very, very, very fun job. If you're a multitasker in nature, this would be great for you to do. Basically, we run reports to see outstanding monies that are due to the facility. We can run a report for patients that owe money, and we can also run a report for the insurance company that owes us money. And what happens is we call the insurance company, we give the patient's information, and we determine why the claim is still pending and has not been paid. During this time, you would type the information in that the rep is giving you. I advise you to get the phone number, the person you spoke with, the reason why the claim has not been paid or it's still in pending status, and you are to want to get a date of when this claim will be paid. Accounts receivable, again, is towards the end of the revenue cycle, and it is a fun job if you are a multitasker by nature. If you like to talk to a lot of people, if you like to do research and try to figure things out, that's a great job for you. If you're more want to sit in your cubicle, quietness, read, and be a coder, then there you go. But again, the accounts receivable or the revenue cycle encompasses about 10 different positions. So there are numerous jobs for all healthcare professionals that are currently going to school to receive their certifications, their bachelor's and master's. So it's just you have to continue to apply, submit your resumes, and eventually you're going to get your chance just like everybody has. Okay? So the revenue cycle has a lot of different fun jobs that you can get involved in. Even if coding is your desired job, there's nothing wrong with starting in the ER, working in the ER, or doing registration or scheduling, because eventually coding positions do open up that you can apply for within the hospital or outside of a hospital. Okay, so the timely filing limit. This is important because we have a year to the date of service to file a claim. I would like to share a real quick story with you. When I was doing work in Las Vegas, culinary is the biggest payer out there besides Kaiser Permanente in the West Coast. And because Las Vegas does not have a very good healthcare system, culinary decided to change their timely filing limit from a year of the date of service to 45 days. So when this occurs, that means the facility, the provider, they have to write off those charges because they did not submit the claim within 45 days. So please make sure claims should be dropped anywhere between, well, if it's inpatient or outpatient. If you're not waiting for pathology reports or any labs, claims should be dropped within 24 to 48 hours after the patient is being seen in an outpatient setting. Even in inpatient settings, there's concurrent billing for the administration of drugs, so on and so forth. So billing is constantly being done. All right, local coverage. We call them the LCDs. You can find this on www.cms.gov. I would definitely add this to my favorites. CMS.gov is the rule of the roost. What they say, what goes, and what goes is what says. If that makes sense. So the LCD, basically what it is, you would go on to, again, www.cms.gov, and you would go ahead and type in your procedure code, and it will list for you all of the ICD-9 code diagnoses that matches that makes it medical necessity. Okay? For instance, if you have a fracture of the tibia and they wanted to do a manipulation, add a plate and some screws, that would be considered medical necessity because when you go under the local coverage determination, you would type in the manipulation, you would type in the implant for the screws and the plate, and you would give the fracture, let's say tibia, and then that would be a covered procedure. Okay? So remember, make CMS.gov your best friend. All right, Medicare Part A and Part B, real quick. Medicare Part A is for inpatient hospital only. Okay? So that means that the patient comes into an insurance or into a physician clinic and they submit their Medicare card, their red, white, and blue card, and it only has Part A on it, they're going to have to pay 100% out of pocket because they do not have the Part B and facility benefits. Okay? So again, Part A is for inpatient hospital, and you bill those claims on the UBO4, and then Part B is for outpatient services only, and that gets billed on the CMS 1500 claim form. All right. So, wanted to ensure again that you become very familiar with www.cms.gov if you haven't already. And when you get to your jobs, make sure you add that to your favorites because all updates, daily updates, they will be listed on that website. So if they tell you they no longer accept the modifier, they're going to put it right on the home page. We no longer accept modifier 50. Please submit your claims with this modifier. And that's from personal experience, so please make sure you save your CMS.gov under your favorites when you get to your positions. All right, thank you very much for Chapter 13, and I will see you soon. Take care.